So the next topic is gastrointestinal ischemia. So acute mesenteric ischemia is something very important in the ICU. So it's defined as a group of diseases characterized by interruption to the blood supply to varying portions of the intestine, leading to ischemia and secondary inflammatory changes. So there is interruption of blood supply leading to ischemia, secondary inflammatory changes. Incidence is 0.09 to 0.2% of all surgical admissions, acute admissions to emergency department. The mortality is very, very high, 50 to 70% if you delay the diagnosis. So the types of acute mesenteric ischemia is broadly classified into occlusive, non-occlusive. Non-occlusive is nothing but spasm or vasoconstriction is something we can consider. Occlusive is divided into arterial, venous. Arterial can be either a thrombosis or an embolism, and venous can be a thrombosis. So you can broadly classify the primary etiologies as mesenteric arterial embolism, which is the most common, 50% of all the cases. Mesenteric arterial thrombosis, which is 15 to 40%. Mesenteric venous thrombosis, which is very less, that is less than 10%. And non-occlusive mesenteric ischemia, which is approximately 20 to 25%. Okay, it has recently increased to 25%. So when we are considering the risk factors or differentiating factors between the mesenteric embolism, mesenteric arterial embolism, arterial thrombosis, and non-occlusive mesenteric ischemia, the embolism, the patients will have a history of atrial fibrillation. Mostly 50% of the patients have a history of AF, recent MI, a cardiac thrombi, poor LV function, any cardiac valve issues, endocarditis or atherosclerotic aorta. It can be due to atheroembolic also. And mitral valve disease, any ventricular aneurysm, and previous embolic disease like a embolic stroke, which should have happened in the patient. So these are the risk factors for arterial embolism. Arterial thrombosis, it is due to mainly diffuse atherosclerotic disease, vasculitis, mesenteric dissection, or mycotic aneurysm. Whereas when we are considering non-occlusive mesenteric ischemia, always remember there is vasoconstriction. So it could be a low perfuse state, like low cardiac output, low flow states, cardiac failure. Patient will be on some vasopressors, resulting in vasoconstriction. So something like an abdominal compartment syndrome. The cause being SMA vasoconstriction due to low splanchnic blood flow, severe coexisting illness, particularly cardiac failure precipitated by sepsis. Main precipitating factors would be hypovolemia, vasoconstrictive agents. The risk factors, cardiac failure, recent cardiac bypass surgery, vasopressor use, hemodialysis. So these are the main precipitating factors. So clinical onset, how can these three differ? Okay, in embolism, there is sudden, strong abdominal pain. So always in mesenteric ischemia, remember the pain will be out of proportion. So this is abdominal pain and vomiting. In arterial thrombosis, there is an increase in postprandial pain. So whenever the patient has some food, the pain increases because the blood supply is shunted off. So the patient has a high pain postprandially. Progressive pain, diffuse episodic pain happens in non-occlusive mesenteric ischemia. So what are the vessels that are commonly involved? In arterial embolism, the SMA is more commonly involved, whereas in thrombosis, either the celiac trunk SMA or inferior mesenteric artery origins. So these are the vessels that have been involved. In non-occlusive, it could be a superior mesenteric vein progressing to a portal vein. So it can happen. So when we look into each and everything in specific, SMA embolism, so the vulnerability of the SMA is because of the large diameter and a low takeoff angle from the aorta. So usually the embolus lodges at a site which is 3 to 10 centimeter distal to the origin of the SMA, sparing the proximal jejunum and the colon. So more than 20% of the SMA emboli are associated with concurrent emboli to other arterial beds also. In case of thrombosis, okay, we already saw the patient will have postprandial pain. Because of that, the patient will not have food. There will be weight loss. There will be food fear. Okay. So frequently due to celiac occlusion, the ileocholic artery involvement can cause a necrosis of the entire proximal colon. In case of mesenteric venous thrombosis is mainly due to a triad. We know the Virchow's triad, which involves stagnant blood flow, hypercoagulability, and endothelial damage. This venous thrombosis is usually because of local pathology, like some inflammatory process which is going on. A pancreatitis, irritable bowel syndrome, or some surgical trauma like splenectomy, bariatric surgery, hypercoagulable disorders like factor V laden mutation, prothrombin mutation, protein SC deficiency, antithrombin and deficiency, phospholipid syndrome. So all hypercoagulable disorders, vasculitis, malignancies, hematological disorders, contraceptives, fibrinolysis shutdown. So all these things mostly can occur in young patients, 36% without any obvious cause. Okay. So GI bleeding can be there in about 10% of the patients. So clinical presentation. So pain will be out of proportion to the physical findings. So this is very, very important. Nausea, vomiting, diarrhea. Triad includes fever, pain, positive occult blood in stools. Signs of peritonitis can be there. Lab parameters, elevated lactate, which is very important. Leukocytosis can be there in 70% of the patients. Lactate more than 2. Whenever a patient has abdominal pain, high lactate should prompt a CT angiogram. D-dimer has a specificity of 60, sensitivity of 82. Amylase can be elevated. Other biomarkers is IFAB, alpha GST, citrulline, D-lactate. So these are all not very reliable. So when you do a CT angio, so this is something that is a gold standard. If you delay the diagnosis by 6 hours, it doubles the mortality. So in CT, you can find specific findings, like you can detect SMA thrombosis, free fluid, portal or splenic vein thrombosis, pneumatosis intestinalis, portal venous gas, free air. If there is a blood supply that has been affected, bowel necrosis can also be seen, gangrene. So these are the specific findings. In non-occlusive mesenteric ischemia, the vessels will be mostly patent. In venous thrombosis, thrombus in the SMV. So there will be a target sign. A target-shaped bowel wall can be seen caused by thickened hyperattenuated bowel mucosa and a submucosal edema from venous congestion due to impaired blood flow. So because of venous congestion due to impaired venous drainage, it will result in a target-shaped bowel, which is known as target sign. And this results in increased inflammation, increased permeability, pneumatosis, splenomegaly, and ascites. So these are the other findings. Diagnostic angiography differentiates between occlusive and non-occlusive. Duplex ultrasound has a limited role. MRI, it has a limited role in emergency setting. So mainly management differs in all these three conditions. For thrombosis, arterial thrombosis and embolism, it's almost the same. Non-occlusive mesenteric ischemia and venous, it differs. Okay, so when there is a suspicion of mesenteric ischemia, go ahead with the CT angio. First, correct hypovolemia, electrolyte imbalance, stop enteral nutrition, continuous Riles tube aspiration, abdominal girth monitoring, normally something that we do in our ICU. Basic CT to look in for occlusion of vessel. So if there is a arterial thrombus or embolism, so if there is an arterial occlusion that is present, consider revascularization, either endovascular or surgical. Okay, and go ahead with full anticoagulation. If there is an arterial thrombus, you have to start antiplatelets and statins. If there is a venous thrombus, full anticoagulation. So you need to remember, for venous, full anticoagulation, arterial thrombus, antiplatelets and statins. So if the arteries are patent, okay, there is no obvious occlusion. So it means there is non-occlusive mesenteric ischemia. So there can be narrowing of the arteries. So what we have to do is optimize the etiological factors. The cardiac functions need to be optimize the volume status. Try to come down on the vasopressors. If make sure your intra-abdominal pressure is optimized. Consider intra-arterial vasodilatation if possible. If there are signs of transmural ischemia, okay, if there is pneumoperitoneum, absent bowel wall enhancement, pneumatosis intestinalis, so this means the patient is very unstable, might require a surgery. Okay, patient is clinically unstable, signs of peritonitis, elevated lactone, abdominal compartment syndrome. So these are the indications, okay, specific indications for surgery. Okay, when they do a surgery, they will see about two things. One is revascularization of the vessels. Second one, if the bowel is non-salvageable, okay, they will have to go ahead and resect. Okay, and the resection zone, like your which part to be exactly removed and which is the viable and the non-viable part, is very difficult to intraoperatively tell, because the margins can also be at a risk of ischemia. So always consider a relook surgery. So a day later or 24 hours, they may not even close the abdomen fully. Or second day, they can have a second relook. And start the patient on, remember, antibiotics, very essential. So improve intestinal perfusion by maintaining oxygenation, treat hypovolemia, optimize cardiac function, make sure avoid hypervolemia and hypovolemia, minimize vasoactive agents, control of intra-abdominal hypertension, and withhold enteral feeding until the perfusion is assured. So this is the management aspect. So remember, it's different for venous thrombosis, full anticoagulation. For embolus, it's full anticoagulation. Arterial thrombus, antiplatelet and statin. For non-occlusive mesenteric ischemia, the main thing would be correcting the etiology. So immediate management, this is a exact same slide, wherein fluid resuscitation, then maintaining electrolytes, NG decompression, broad spectrum antibiotics, then revascularization techniques, embolectomy, angioplasty, bypass, hybrid techniques like retrograde open mesenterics can be considered. Surgical intervention when there is signs of peritonitis. So laparoscopy can be done and assess the extent of necrosis, and then make sure the blood supply is established. If not, bowel viability assessment is very critical. That is, it can be done by inspection. It's very difficult. They'll apply a difluorescent or Doppler or the indocyanine green dye application. So these are the methods by which they'll assess the bowel viability. So arterial thrombosis, antiplatelet statins, venous thrombosis, anticoagulation, emboli, anticoagulation, therapeutic anticoagulation. NOMI always treat the etiology, okay? And post-operative care, long-term management, because the patients are at a risk of nutritional compromise. So nutrition is something that needs to be taken care of. If your nutrition is compromised for a considerable period, consider parenteral nutrition, antibiotics, anticoagulants, and if the patient might have a reperfusion injury also. Okay, long-term need to consider anticoagulation, antiplatelet therapy. So this is about acute mesenteric ischemia.